Good afternoon, everyone. Welcome to today's webinar. I would like to remind you that this conference is being recorded. At the moment, all participants are in a listen-only mode. For those that are connected by telephone and require operator assistance during the call, please press *0. For those online that require assistance, please use the chat box on your screen. I would like to now hand the meeting over to your host, Neil Drimmer, Director at Canadian Foundation for Healthcare Improvement. Please go ahead.
Thanks so much, and welcome to the Priority Health Innovation Challenge webinar series. My name is Neil Dreimer, and as Director for the CFHI Challenges team, it's my pleasure to be joining you as the host for today's webinar. I do want to start by saying that CFHI is committed to reconciliation and by acknowledging that we are meeting on land that has been inhabited by Indigenous peoples since the beginning. In particular, we acknowledge that we are hosting this webinar from Ottawa, which is the traditional and unceded territory of the Algonquin Nation. We recognize and deeply appreciate their historic connection to this place and the opportunity to gather here today. At CFHI, we continue on our learning journey and commitment to support improvement with and for all people in Canada. We want to thank you and acknowledge everything that you're doing in these challenging times. I also want to highlight the chat box on the bottom right of your screen. Feel free to just chat in right now who you are, the organization that you're joining from, and the place and or traditional land that you're joining us from. Just a couple of housekeeping notes. We are pleased to host all Priority Health activities, including this webinar, in both official languages. If you wish to view today's slides in French, please let us know in the chat box now. The telephone number to connect to the French audio will be on the screen once you are transferred to the French room. And at any time during the webinar, please feel free to send in your questions using the chat box in either official language. So today, I'm so excited to be welcoming many of our Priority Health Innovation teams as presenters. They will be sharing a 5-minute overview on their innovations and how they've increased access to mental health and or home and community care services. We also want to welcome the many guests who are joining us from across Canada to hear about your innovations. We added this webinar specifically so that teams could be able to share all the good work they are doing with a broader audience. Please use the chat box throughout the webinar to ask questions. We have some specific times during the webinar where we will be addressing questions, but teams will also be looking to address some questions in the chat box throughout the call. I'd also like to give a shout out to my colleagues, Lindsay, Sabrina, and Emily, and all of the great CFHI staff who are working the webinar behind the scenes. Lindsay, Sabrina, and Emily will be your go-to people if you have any questions for the Challenges team in the chat box. So with that, again, today you'll be hearing from 10 of our Priority Health teams, 6 from the home and community care sector, and 4 from the mental health and addiction space. I'd like to give them a warm welcome, and I will also be introducing them individually before each of their presentations. And it's great to see, I'm just looking up, there's a lot of people who have already chatted in, so great to see that. In terms of what we're focusing today, I mean, you will hear a little bit more about where we are on our Priority Health journey, but again, the focus of today's webinar is really from our teams on learning about the great innovations that they're embarking on. So in terms of where we are on our journey, this is our penultimate, I like to say that fancy word, or our second to last webinar of the Priority Health Innovation Challenge series. For enrolled teams, the overall challenge award and your final data submission is due October 20th, so just under a week, and the winners will be announced at our final webinar on November 16th. And just a reminder that Priority Health is supported by 20 supporting organizations from across the country, some of whom are on the call today. And you could see the list of those great organizations on this slide. And on this slide, you can see a snapshot of the teams from across Canada. It's really great to be able to say we have a total of 33 Priority Health teams joining us to highlight how they are innovating to improve access in mental health and home and community care across Canada. So, without further ado, I think we should get started and hear from many of them. Just a reminder to all of our presenters today, to please ensure your computer speakers are muted to prevent any echoes when you present. Also, a reminder to our teams that we have a strict 5-minute presentation time per team to ensure we have enough time for all of our presenters today. I will be jumping in at the 5-minute mark to help us move to the next speaker if we go over that 5-minute time frame. And as well, to help you along, you'll also have a visible timer that will be counting up to 5 minutes once you start speaking. To help with the transitions, I will be also advancing the slides, so if you can please just say next slide, and I will move them for you. Again, to the audience who's joining us, feel free to start chatting in your questions throughout the webinar. And to just better be able to direct your questions, I just ask if you could indicate to whom your question is directed to. You'll also note that many of the teams will have questions for you, the audience, so feel free to use the chat box to address the questions they share. We'll take a pause after hearing from the first 5 teams to address some of those first questions. So with that, I'd now like to introduce our first team who's working in the mental health and addiction space. And forgive me if I mispronounce your name, Jackie, but I'd like to introduce Jackie O'Frick from the Calgary Foothills Primary Care Network, who will speak about their Case Collaboratives program. So over to you, Jackie.
Thank you so much. My name is Jackie Offrich, and I work with the Calgary Foothills Primary Care Network. And today I'm going to speak to you about the Case Collaborative initiative that we've had going for about 3 years. This Case Collaborative initiative is truly a partnership between us, Alberta Health Services, our education partners, and our social service partners as well. Next slide, please. So the problem we're really trying to solve is that our current system is truly fragmented across sectors in the mental health space. We've heard from families that they really have difficulty navigating the system, and this includes trouble with access, duplicate referrals, safety concerns, not knowing where to go or who to turn to. And we've heard this from providers as well. They feel the system is really challenging to navigate. So we wanted to come up with something really simple. We essentially built a frontline table very similar to rounds, but with multiple sectors involved. And all the frontline providers come together monthly to discuss a family situation and try to come up with an integrated care plan. The Case Collaboratives have been formed in 2 communities. We currently have one in Cochrane, focused on children and youth, and one in Bowness for older adults. Next slide, please. So we do have multiple sectors involved. We've had 16 organizations represented at our table. So as an example, for our child and youth table, the schools are there. We have Alberta Health Services, we have primary care, disability support, social services, you name it, we kind of have it at the table. We try to keep the organizations really broad, so anyone that can benefit from the table can present. So, in Westbow, for example, we've had a subsidized housing provider come present a case because she had a resident she was really worried about. So anyone who can benefit from the table is welcome to join us to present a case. So far, we've discussed 136 cases, which I know that reach isn't very large, but it's not really meant to be. This intervention is really focused on families who have multi-sectoral needs and a lot of things going on in their life. And so the reach isn't that big, but the impact is quite big for them. I'm going to come back to this, but we've really been focusing on building a culture of collaboration among sectors as well, and really trying to build relationships with frontline providers in the community. We believe these relationships are the true foundation to collaborative care. Next slide, please. So speaking to some of our achievements and outcomes, we've collected some surveys from our providers and our patients, and I'll highlight a few key aspects here. The access to mental health services was noted by many members. So 85% of our providers stated that being a part of the collaborative helped them facilitate a timely connection to resources for patients. They also thought the quality of care that they provided was improved, and the providers themselves felt better supported to provide care for the patients. This past year, some families have also begun joining the Case Collaborative table, which is a really exciting development, and patients report feeling really well supported. Generally, families are coming to our table really frustrated by their experience in trying to access care and coordinate all the different pieces that they need. And this table really provides an opportunity for them to come and talk to all of the providers that they have currently in their life, maybe meet some new providers who can get involved if they have specific needs they can address, and really an opportunity to get everyone on the same page. One of our patients really explicitly noted this. They felt supported because their family doctor, their therapist, and other social services were at the table with them. Again, I want to come back to this shift in culture that I alluded to earlier. We really want to build relationships so that all families can benefit from coordinated wraparound care, and we are seeing this actually in our survey results. So 88% of our providers who come to the table believe that they've strengthened their relationships to other providers and organizations, and that they've actually tapped into these relationships when they had a patient outside the collaborative that could benefit. So it's having a broader reach than just the cases coming to the table. Next slide, please. In terms of next steps, we're always trying to refine our current processes. We've been working on some communication materials, including shooting a video, but that got a little bit delayed due to COVID. We're also really trying to build some infrastructure. So online booking is a way that we're looking at getting some referrals built in, and this will really help us with spread and scale. Our partners in Cochrane have already organically started a seniors table after seeing how successful the Child and Youth table was. And similarly, in Northwest Calgary, we're going to start a table for child and youth in 2021. The long-term vision is really to create this culture of collaboration, as I've said numerous times through this presentation. So anytime a family really needs that multi-sectoral care, it's second nature for partners to come together and wrap around the family. We know this shift takes time and requires relationships to be built, but we really feel like we're making good progress with what we've built so far. So again, hoping to spread and scale this to populations in the future. Thank you for listening today.
Thank you so much, Jackie. And folks, I think you could see one of the questions that Jackie didn't have time to address on the screen, but how do you include primary care into your multidisciplinary approaches in mental health? So feel free to chat in any thoughts on that. And with that, I will now move to our next speaker. I'd like to introduce Laurel Stretch from the Alberta Health Services Home Care Measurement Framework team. Please go ahead, Laurel.
Great, thanks very much, Neil. Good morning and afternoon, and thank you for the opportunity to present on the exciting work underway across the province of Alberta. My name is Laurel Stretch, and I'm with the Quality Management Team in the Provincial Seniors Health Portfolio, and today I will provide a brief overview of the work underway on the Home Care Measurement Framework. Next slide, please, Neil. Over the last few years, measurement in home care has become a national and even international priority, and things are no different here in Alberta. In alignment with several key initiatives in Alberta, such as our home care redesign and enhancing care in the community, it became apparent that several key opportunities existed. Among those were the need to shift home care measurement from a purely transactional model to one where the focus is on our clients, families, and the outcomes of care in a more holistic manner. Secondly, the need to balance the viewpoint and be inclusive of the client and the family perspective while considering clinical outcomes and aligning with organizational priorities. And lastly, the need to support public accountability and transparency by supporting the work underway in Alberta on the performance management process for home care service providers. The solution these key opportunities generated was the development and implementation of a comprehensive measurement framework and the tools to support home care teams in achieving excellence in quality. Next slide, please. We've been successful to date in achieving multiple key milestones in this very large project. Those include creation of the overall approach and the framework along with the supporting tools. We've received approval and concept of this approach and the tools. We've been able to draft key indicators, including those related to client demographics and trends, client and family experience, outcome measures inclusive of RI, as well as system flow and performance measures. In addition, we've also been able to link to population health measures and incorporate system integration measures. We've identified potential pilot programs in Alberta and who are working on quality improvement initiatives, and we're collaborating with them currently to explore opportunities. Next slide, please, Neil. Over the next few months, we'll see immense progress as we move to full implementation. We'll be continuing to engage with our key stakeholders, including operational leaders, clients, families, and academia. These tools will be reviewed, updated, and re-engineered as needed to meet our end user needs. As results from our pilot program become available, we'll be looking for opportunities to share successes and stories of how teams are using the tools to support safe, quality care. The question we have for the group in order for us to position ourselves and be proactive is if any teams have encountered barriers and challenges to use of measurement systems in home care environment and any solutions which have worked. And I'd also like to thank you again for the opportunity to share our work in Alberta.
Thanks so much, Laurel, and really appreciate the work that you're doing. And again, folks, feel free to chat in any thoughts, comments, or questions or answers to that question that Laurel posed to you all. And I'm sure many of you might have some thoughts about using measurement in the home care environment. So feel free to jot those down. All right, so I think we're going to move on to our next speaker, and it's now my pleasure to introduce another of our teams working in the home and community care sector. I will introduce Kathleen McQueen from the CBI Home Health Group in Etobicoke, Ontario. Please go ahead, Kathleen.
Hi, Neil. Thanks very much for the introduction. So hello to everyone on the CFHI webinar today. A special thank you from our CBI Health team for giving us the opportunity to share our Care for the Caregiver program and some of our key achievements. Congratulations goes out to all of the participants in the webinar today. Next slide, please. So the problem that we are trying to solve. Caregivers are stressed out like never before. They are supporting an increasingly aging and complex population with fewer resources and little recognition. As the front line of care and the backbone of the healthcare system, we need to act urgently to find better ways to support caregivers and enable Canadians to age well and in their own homes and communities. Despite caregivers being the foundation of the healthcare system, they remain the least researched and understood human health resource. But what if we reimagined how we support caregivers? Next slide, please. At CBI Health, we are doing just that. About 2 years ago, we developed the Care for the Caregiver program, a program where we use data to drive customized, efficient, and integrated caregiver solutions. Our Care for the Caregiver program applies a tiered and personalized approach to caregiver screening, assessment, and intervention. Tier 1 supports include a check-in with every informal caregiver, starting off by simply asking them how they are doing. We are taking the time to validate the importance of their well-being and the crucial care that they provide. Tier 2 supports include a more formalized screening and assessment process where we work alongside the caregiver to identify specific areas of stress that can be targeted for intervention. And Tier 3 supports include an expedited referral network where we connect caregivers and families with the right supports and services at the right time. Next slide, please. So over the last 18 months, we have learned so much about innovation, program implementation, and sustainability. And I think all teams participating in the CFHI Priority Health Challenge have graduated from a rapid university-level course in resiliency and pivoting thanks to the COVID-19 pandemic. We have all learned so much. We'd like to share with you some of our key achievements and impacts as the results of the challenge and our spreading and scaling of our C4C program. It would not have happened without the structure of this challenge, the CFHI team, or our caregiver partners. Perhaps our biggest achievement was our ability to partner with several Canadian universities during the pandemic to offer an enhanced version of our Care for the Caregiver program. We offered a virtual placement to graduating occupational therapy students across Ontario. We trained them on how to deliver the Care for the Caregiver program, screening for caregiver distress, and providing outreach and intervention for caregivers in need of support, coaching, or encouragement. There was something truly special about the cross-generational connections that were made via this program and partnership. Most importantly, we were able to develop 65 new caregiver champions that provided support to caregivers during an unprecedented time. We are so hopeful that they will carry their awareness, experience, and passion for caregivers across their healthcare journeys, wherever that might take them. Just imagine the possibilities. Another key achievement was our ability to build our base of knowledge around caregivers in general. By collecting data and analyzing our results, we have a better understanding of what contributes to caregiver distress and how to better support them. Did you know that the top 2 areas of caregiver distress include family adjustments and personal adjustments, and that the primary interventions requested by caregivers is simply for support, encouragement, education on self-care, and how to better care for their loved one? Did you know that the least reported cause of distress was financial strain? This might mean that we need to do a better job of screening and intervening on social determinants of health. Another key achievement for CBI Health was facilitating a standardized approach for screening for caregiver distress across our home health teams in 13 of the 14 LHINs. We have embedded key questions in the Caregiver Strain Index into our interdisciplinary initial assessments to facilitate an early identification approach to caregiver distress, and more importantly, ensuring that all caregivers are acknowledged. This translates into hundreds of thousands of caregivers a year. Based on our population reach data and our outcome measure data, we have offered customized intervention plans to 100% of our caregivers screened for distress, and 100% of these caregivers reported that they found our programming helpful and would like additional follow-up. We've also decreased levels of caregiver distress as indicated by our pre- and post-CSI scores. Via our collection of qualitative data through comprehensive interviews and surveys, we also know that our C4C program has had a positive effect on patients, caregivers, and providers. Some key impact statements include, I always felt better after your calls. You're the only person I can talk to about this. I've had to quit my job to take care of my children. And when we asked our caregiver partners for feedback, they offered the following meaningful statements. I hope my mom can forgive me. I wasn't always at my best. And no one ever asked me how I was doing. They assumed because I was young that I shouldn't be a part of care planning. And lastly, from a provider, this is meaningful work. I feel like they know that they have me in their corner. Finally, throughout the challenge, we have accomplished some transformative outcomes. We, like many of you, expedited our transition to offering virtual care in a matter of days, not years. Thousands of our providers were trained in delivering virtual care. In our last quarter, we have delivered over 30,000 home health virtual visits. This opens up a new world of possibilities for supporting caregivers that need to be explored. We also saw our primary home health funder recognize, acknowledge, and highlight essential family care by enabling providers to bill for caregiver services delivered. Next slide, please. So perhaps one of our biggest takeaways from the Priority Health Innovation Challenge is that innovation is an iterative process. We need to keep moving, adjusting, and enhancing our Care for the Caregiver program to ensure that it meets the needs of our patients, families, providers, and communities. We need to keep our foot on the gas pedal. With our recent CFHI mini challenge win, we have launched into a new C4C challenge where we are looking to identify new caregiver champions across CBI Health nationally that can continue to spread this important initiative. We will continue to look for new partnerships and expand existing ones to ensure that we can keep our momentum moving forward. We have untapped resources in students, personal support workers, and other healthcare providers to better support caregivers. These resources need to be explored and optimized. We will continue to investigate digital service offerings that can enhance and simplify the way we support caregivers and their delivery of essential family care. And we will continue to advocate. Our C4C program, our caregiver partners, and our CFHI collaboration has set the stage for a powerful advocacy platform, and the time is to act now. Thank you.
Thank you so much, Kathleen. You packed a lot into those 5+ minutes, so really appreciate what you shared. And I do see your question on the slide, what do you think the #1 request of caregivers is? So feel free to jot your thoughts down and your questions for Kathleen in the chat box. And moving right along, and I think we have 2 more presentations, and then we'll pause to go over some questions. So our next presentation is from Claire Doherty from the Virtual Psychiatry Collaboration with Vancouver Primary Care and Providence Healthcare in Vancouver, British Columbia. You can go ahead, Claire, please.
Great, thank you so much. So I am a project leader with Providence Healthcare in Vancouver on the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. I'm going to talk to you about virtual psychiatry consultations, or VPC. We went through a few different iterations of the name, but this is what we've landed on. This project has been co-developed by a diverse team that includes patient partners, psychiatrists, family physicians, a medical student, nurses, clerks, social workers, and managers. The initiative is funded by BC's Shared Care Committee, which is a partnership between Doctors of BC and the BC government. Next slide, please. Great. So on this slide, you can see the map, which shows Vancouver City Centre. The red dots represent primary care offices. This is the focus for our initiative. In this area, there's limited access to adult psychiatry for non-acute mental health concerns, but the need is significant. For example, 11% of residents have a mood or anxiety disorder. BC's median wait time for a psychiatric consultation is 10 weeks. Many people with moderate mental health concerns aren't able to see a psychiatrist at all, and they receive all of their mental health care from a primary care provider. The objective of virtual psychiatry consultations is to improve patients' and family physicians' access to psychiatric advice. Originally, we chose virtual visits because office space is limited in the Vancouver area, and we wanted to give patients and psychiatrists the flexibility of joining a visit from any private place. One silver lining of the COVID-19 pandemic is that more psychiatrists have become comfortable with virtual visits, and that has made them more interested in joining the Virtual Psychiatry Consultations Project, and it will help it be sustainable. Next slide, please. The pandemic has delayed our timelines, but we'll be launching the actual virtual psychiatry consultations within the next few weeks. At first, we'll only accept referrals from family physicians in Vancouver City Centre. We want to start small and do some iterations and then scale up. We're focusing on patients aged 19 to 64 because there are already dedicated mental health programs for youth and seniors. Virtual psychiatry consultations is aimed at patients who can receive most of their care from a family physician, specifically those with anxiety, depressive, bipolar, or schizophrenia spectrum disorders. The virtual psychiatry consultation service is not intended for patients with dementia, active psychosis, or an immediate need for crisis intervention, or those who are already connected with a psychiatrist or mental health team. Next slide, please. Over the summer, our project team formed into several task groups to develop a workflow diagram, rule descriptions, a patient handout, feedback forms, and reports. This slide shows an excerpt from our patient handout. So it walks through the patient journey. Patients will be referred by their family physicians, have an intake conversation with a nurse case coordinator, complete about 1 to 3 virtual psychiatry appointments, and then return to their family physicians for ongoing care. Next slide. Thanks. Within the next few weeks, 4 psychiatrists will begin accepting referrals from 6 family physicians who are all based in the Vancouver City Centre area. The project team will have monthly check-in meetings where we'll discuss the feedback forms and the reports for evaluation purposes. We'll adapt the model as needed based on the evaluation results. One of our main indicators for the evaluation is median wait time. We definitely want to do better than BC's current median wait time of 10 weeks from referral to psychiatric consultation, and we're aiming to keep that wait under 5 weeks. We plan to scale up the model gradually by engaging more psychiatrists and inviting additional family physicians to refer appropriate patients. The virtual psychiatry consultations model is based on the recognition that due to limited mental health resources, many patients will receive most of their mental health care from a family physician or nurse practitioner. So my question for all of the participants is, how can we support primary care providers to be effective partners in their patients' mental health journeys? Thank you very much.
Thanks so much, Claire. Really appreciate the work that you and the team are doing in Vancouver and really focusing on improving access to virtual psychiatry. So again, folks, any questions you have for Claire, feel free to use the chat feature, and we'll now move on to our last presenter in the first 5 before we pause for questions. So moving from Vancouver to Ottawa, I'd now like to introduce Amélie Deslauriers from the Children's Hospital of Eastern Ontario, CHEO, and she'll be speaking about their Navigator program. So please go ahead, Amélie.
Thank you very much for this introduction. As mentioned, my name is Amélie Deslauriers. I am a registered social worker / system navigator with the Navigator program. So today I'll make a short presentation of what the Navigator program is, what we've accomplished so far, and what our next steps are. Next slide, please. So as an introduction, the population that our program serves are the parents or caregivers of a medically complex or fragile child or teen under 18 years of age who is currently receiving services from CHEO. The child or teen must have at least one of the following: multiple medical issues and or multiple specialty teams involved in care, or a chronic condition that requires ongoing, frequent, or time-consuming medical interventions, including 24-hour management of care. The Navigator program was co-designed by CHEO with system-savvy parents and community partner organizations with an aim to promote the social and emotional health of parents and caregivers, help families access and navigate key supports and services to help parents thrive, increase understanding of the best ways to support families, and find gaps in the system, along with solutions to the problems families often face. There is a critical gap in supporting parents who have CMCs. Their role as a caregiver is most consuming, and the parents speak of not being able to turn off their caregiver role. The care they provide is offered around the clock and requires a state of hypervigilance that can be exhausting at the best of times. These parents experience many challenges when caring for their complex child, directly impacting the social determinants of health. Among the highest concerns experienced by parents caring for a CMC are the effects on the physical and mental health of the parent and increased social isolation. Providing early screening and intervention to support parents will ensure that families thrive and are supported to provide the best life for themselves and their children and youth. The program has 2 parent navigators who provide peer support, and Teresa McMillan, she's also in the chat and she's ready to answer your questions if you want to chat with her. So their role is with the goal of providing the families with a means to socialize, share ideas, and connect with families who share their experiences to end their isolation and improve their well-being. The parent navigators do this by organizing workshops, social events, being present on social media, and supporting parents during admissions and clinic visits. So the system navigators, which is the registered social workers, provide help to families navigating the complex care system and finding funding resources, and also provide one-on-one counseling, family counseling, and caring for the caregiver workshops. The Navigator team aims to help decrease caregiver distress. Next slide, please. So here are some of the achievements and outcomes that we've had so far. The peer-to-peer support continues to be the highest highlight of this program in system navigation supporting families. Despite this crisis during the pandemic, parents and caregivers are reporting improvement in feelings of well-being as indicated by their increased scores on the outcome rating scale. This is measured at every scheduled encounter between parents or caregivers and the system navigator, which can be on a weekly, bi-monthly, or monthly basis. The program has a well-established evaluation framework with patient experience surveys that we conducted every 6 months on a voluntary basis. This allows families to provide input that will directly impact the quality of the support and services you receive from the Navigator program. Another pillar of this program is the knowledge navigation that uncovered the major gaps and challenges faced by these families to raise awareness and build capacity for the system to respond to better support these families through the creation of a national best practices toolkit. The toolkit helps others build and implement programs to better support the needs of these unique parents and caregivers locally, provincially, and nationally. This was launched in October of 2019. There are other programs housed at CHEO that benefited from the original Complex Care Navigator model and co-design and pillars. And our program has also influenced the development of other national Navigator programs, and since the launch of changingyourlens.ca, other programs in development have benefited from our best practice guides on the website. We've also won an award with the Mini Challenge from the Innovation Challenge, which was great. And then last but not least, the Zoom platform was already being used by the team to support parents individually in this program since 2017, and it has been used for group support since March 31st of this year due to the pandemic. So this permitted to support families impacted by the pandemic and to create an online community of support. Over 40 sessions were held so far, and not only were families able to get much needed peer and professional support and access, but their top concerns about the pandemic were shared with the CHEO leadership. Also, parent navigators have led multiple activities for families to address social, emotional, and isolation needs during the pandemic. Over 40 families have participated in these virtual events so far. Next slide, please. So for our next steps, we're seeking new funding for a program focusing on better understanding the impact the pandemic has had on families and how to grow new virtual care supports during the pandemic. We have built websites to assure certain continuity of support to parents, caregivers, and care providers, such as the Resource Inventory website. It's designed to easily find community resources in the Ottawa region. And then there's the changingyourlens.ca, which was created in partnership with Children's Healthcare Canada, and the website will continue to offer the tools for other organizations to create their own Navigator program. And lastly, one of the program's main goals for the next few months is to focus on building the professionals' capacity on better supporting parents who have children with medical complexities, and this will be done in partnership with the Complex Care Social Work Community of Practice and using the tools housed in the changingyourlens.ca website. Thank you very much, and thank you for this opportunity.
Thank you so much, Emily, and the great work that you're doing at CHEO with your Navigator model. So just going to take a pause, let everybody catch their breath for a second. Lots of great presentations in the last 25 minutes or so. Again, I encourage folks, if you have questions for any of the speakers, and here they are, just to remind you, feel free to chat them in. We did get a couple of questions, so maybe I'll start and I'll direct them to specific people, and then we'll also see if there's further questions. So Sharon Anderson from Easy Home Living in Alberta has a question for Laurel, and she's asking, are you including family caregivers in your measurement strategy? So if Laurel's line could be unmuted.
Sure, thanks, Neil. And I did respond in the chat box as well, but so yes, we have had caregivers as well as clients involved in our process. So the development and our consultation with the key stakeholders have gone to a variety of different groups where we have fairly significant representation from patient family advisors. And we also have taken the opportunity to update our provincial advisory council, which is public membership as well, and we will accept feedback from them. As far as the indicators go, we have incorporated the caregiver distress indicators from CIHI, as well as some of them that are generated specific to Alberta. And then we do have the responses from the client experience surveys generated from the Health Quality Council of Alberta are on all of our reporting tools as well.
No, that's great, and I think that that the focus on caregivers is definitely it's visible in some of those shared healthcare indicators that CIHI produced, but I think it's also a common theme that I'm hearing from a lot of the innovations, including caregivers as part of who the programs are focused on. And primary care, that's the other big theme. And I'm also really just trying to keep up with the chat box. I've already seen, and we're continuing to see, that people are sharing resources and contact information to continue to share learnings from their work with each other. So that's great. We have another question from Logan, who indicated he's working, or he or she, pardon me, is working for the federal government. And I think this question is directed to Claire. Claire, I was wondering what options exist for patients who do not have a family physician, and that's always a big question, or even what percentage of your population may fall into this category and may not be viable due to their inability to get a family doc. I know rostering is challenging for some people in Ontario due to the lack of physicians in some areas, so wondering if you can respond, Claire.
Sure, yeah, that's a really good question, and certainly attachment to a family physician is a challenge, and one of our concerns in terms of there being barriers to accessing virtual psychiatry consultations is that around 17% of BC's population doesn't have a family physician, and I believe the number's pretty similar in the Vancouver area. So our initiative is specifically aimed at those patients who can receive most of their care from a family physician. It's a shared care model, so the idea is that the psychiatrist and the family physician are collaborating to help develop treatment that is most effective for the patient, develop treatment with the patient. In terms of mechanisms for patients to get access to primary care, there is a patient attachment mechanism that the Vancouver Division of Family Practice has for particular patients who are have higher needs. There is an urgent primary care center in downtown Vancouver that has some role in attachment, and there's also a Vancouver City Centre primary care network that's under development, and they have a goal of attaching number of patients as well, about 25,000. So there are some different initiatives that are underway on the attachment side of things. There are also community health centers, I should mention, for patients who don't have a regular family physician and other kinds of clinics. So yeah, our initiative is specifically designed for those who do have a family physician, but we want to make sure that we're connecting patients with primary care as much as possible and staying in the loop about some of those other initiatives.
Thanks so much, Claire. And I think I have one more question. This one is for Kathleen, and it's from Zaina, and she said she may have missed this, but are you able to include the time and effort to do the caregiver assessment and interventions programming as part of a billable service funded by the LHINs in Ontario, for example? So I don't know, Kathleen, if you can address that one.
Sure. Yeah, the answer to that question is a little bit yes and a little bit no. So the way that our visits are funded in home health is that we have the fee-for-service billing rates for all activities that are associated with the actual visit themselves. But if you work in home health, you know that there's a lot that goes into the planning and the efforts and the documentation and connecting to resources that isn't necessarily included in that billable time. So a bit of yes and no, but it's been a a great change for our providers in terms of having almost that permission and that recognition of the essential family care to be able to look towards the caregivers and ask those questions and feel like they have the autonomy to intervene. So it's been a great change.
Thanks so much. And now maybe I'll just go to the two speakers who haven't addressed the question, and just more of a general question, and maybe I'll start with you, Jackie. Wondering if you could just give a short thoughts on what's the most important thing you learned from your innovation so far?
Yeah, thank you for the question. I think I've harped a lot on the building of relationships and the importance on that. So I'll answer this one a bit differently, but want to highlight that as a sort of a key component. I think one of the things that we've really learned since doing this is really the complexity and the isolation of some families, where certain providers in their life aren't even aware of what's going on in their lives. And, you know, for many reasons, some specialty services and other sectors have built strong relationships, but primary care really hasn't been a part of the picture. And that, you know, having the family doc be a piece of the care plan is extremely important. And so we've been a little bit surprised by the awareness of our family docs on some of the situations that have come up, and just not being aware really of the circumstances of the families they're caring for, and not having that full picture. So we've been working towards that with the CASE Collaborative in trying to address that gap for sure.
No, thanks so much, Jackie. And yeah, I think that is a theme for sure in several of the innovations that we're hearing from so far. Emily Achio, do you have any thoughts about what's the most important thing you've learned so far from your innovation?
Yes, thank you very much for the question. So one of the most important things that we've learned, especially through the feedback received from our patient experience surveys, is that the parents and the caregivers appreciate the role of the parent navigators who offer the peer support. So parents and caregivers continuously mention how comforting it is to speak to another person who gets it, who has lived experience, and we've realized how big the role, or crucial their role, of parent navigators is for this program.
That's, I know, an excellent point, and we've heard again and again on the importance of peer-to-peer support in various programs, so thanks for highlighting that. So definitely feel free, if other thoughts come to mind, folks, for our first 5 presenters, feel free to chat them in. And I think we're just in the interest of time, we're now going to continue on with our presentations. So I'd now like to introduce, going back to Edmonton and Alberta, Sharon Anderson from Alberta Health Services Edmonton Zone Enhanced Home Living Program. Please go ahead, Sharon, and just a reminder, you have 5 minutes and I will advance the slides for you.
Thanks very much to the CFHI for doing this. Sharon Anderson, I've been the research coordinator on this project. I'm so pleased to represent the Edmonton Zone Home Living Support Pilot Program today. Next slide. Depending on the province, about 20 to 30% of the people admitted to long-term care have the same needs as people who could continue to be cared for in the community. Yet, people want to remain in their own homes for as long as possible. So what we targeted, who we targeted, were the home care clients at highest risk for long-term care admission. Home care staff receive caregiver-centered care education. That's education on person-centered support, specifically to support those family caregivers that are really stressed. We use 2 new tools, the Caregiver Risk Screen to assess family caregivers' distress, and the Caregiver Support Needs Assessment tool to have a conversation with family caregivers about their needs for support in 2 areas, to sustain that care and to maintain their own well-being, which is really important. The home care team could authorize enhanced respite or enhanced independent activities of daily living in addition to their usual, the usual care that they would provide. So next slide. The person and family caregiver-focused system of care gave home care clients and caregivers real choice, and it was flexible and particularly effective for those younger clients and caregivers, minority groups, some of those outliers that we sometimes have difficulty serving. 98% of the clients said it gave them real choice to remain in their home. 57 of 66 clients with the highest risk of residential care, those clients with MAPLE scores of 4 and 5, remained home. We reduced caregiver distress on the caregiver risk screen by almost 1 standard deviation, and the stress reduction was robust. For example, at the 6-month measurement, one caregiver said, "I strongly believe that if this pilot project discontinues, my level of stress will return to the level it was before this project became available to us. My blood pressure is just now starting to stabilize, whereas 3 months ago, it was still dangerously high." We prevented a stroke probably. Staff confidence and job satisfaction increased. They said, this is one care provider, it gives you personal satisfaction as a professional, especially if you like your job and you see that you're actually making a difference. You feel happy. When clients come and see you and say, "I could have not done this without you, thank you," I find it gives you personal satisfaction as well as professional satisfaction. There were system impacts, reduced cost. For those 57 of 66 clients who remained home, there were savings of $486,210 a year, and that's conservatively compared to the cost of supportive living, not the more expensive long-term care that costs $75,000 a year. Next slide. So what are the next steps? The goal is to roll out the program to the entire Edmonton zone and then across Alberta. We understand that the government now sees that caregivers are important. We're going to roll out that caregiver-centered care education for the entire Alberta workforce. Thanks to the funds that we've won, that caregiver-centered care CA education online will be free. We're going to disseminate that caregiver-centered care education for all health providers who work with family caregivers, not just in home care. So contact us if you're interested. Thank you very much. This has been a wonderful challenge, this program.
Thanks so much, Sharon. And again, really great to hear the excellent work and how you're responding to the needs of families in Edmonton, and look forward to hearing more as you roll it out more broadly. And I think I see a question that you've asked the audience. Do you think the health workforce has a role to play in supporting family caregivers? I'd love to hear what people think, so feel free to chat that in. And again, if you have questions for Sharon, please also chat those in. So we will now move on to our next presenter, and we're going to pass it to Monty Ghosh from the Grenfell Ministries, who's going to speak about their virtual overdose prevention line innovation, which spans multiple provinces, as you can see on the slide. So please go ahead, Monty.
Thanks again. Thanks for having us present, Neil. Really appreciate it. And thanks to everyone at CFHI. And it's a pleasure to be here with so many amazing projects. I've got Kim Ritchie with me, who's our executive director as well, on the call to help answer questions too. Next slide. So just want to give a background. So we already know the opioid crisis is getting worse, especially with COVID. We're seeing spikes in overdoses in BC and in Alberta, as well as in Ontario. What's interesting, however, is that 83 to 95% of the overdoses are occurring in suburban populations, in suburban areas, as well as in rural communities. Supervised consumption sites are very effective. They do reduce mortality rates, but studies based out of BC demonstrate that it only reduces mortality rates within a 500-meter radius around it. Beyond that, there is no reduction in overdose mortalities. We do know that naloxone kits are very effective as a tool to deal with overdoses. but we need to figure out a way to scale up supervised consumption sites because not every community can have one. Next slide. So this is a project that's been percolating in different provinces within BC, within Alberta. We've been working on it for 4 years, as well as Ontario, who's been working on it for a while as well. And all of us are kind of working on similar ideas with an overdose prevention line. And today we'll be presenting Grenfell's project. But the overdose prevention line is a line where an individual who's using substances can call this phone line, and they can speak with a peer, and that's a big ingredient there. That's the secret sauce is the peer, the person of lived experience who will supervise them over the phone as they use their substances. And if they stop responding at any time during the phone call, an ambulance is called in their direction. They're told to have, have safe supplies near them. They're told to unlock their front door, remove pets. We make sure that they give us their address so we can get a hold of them and their phone number. But the big thing that this removes is certain barriers such as stigma, geographic distance, again, removing that 500-meter radius issue. In Alberta especially, we have lots of community opposition to physical supervised consumption services, and this helps remove that. And a lot of sites have limited hours of supervised consumption services, so this will help take care and mediate that issue as well. Next slide. So Grenfell has been running a pilot project. They actually ran a pilot project, I should say, for about 3 months in March till about June of this year. The pilot was operating on limited time, but they were looking at key metrics and looking at service utilization, acceptability, as well as whether it was actually feasible to run a service like this. And you can see from our run chart right here that they were actually looking at timings of calls in order to figure out how to best place supervisors and operators on the line. These are the peers, of course. As you can see from the chart, we can see that most of the calls occurring in the evening. Grenfell was able to effectively pivot their resources to support the volume of calls based on this data. But again, we're still in a very early stage of evaluation. Grenfell has stopped running their pilot. They've pivoted towards actually operating the line, and they've gone 24/7 since August of this year. The key metrics that we'll be looking at in the next little bit include acceptability of clients, the utilization of the service and how well it's utilized, how many frequent callers do we have, the safety profile as well. We've had only one overdose, which we were able to safely navigate 911 towards, as well as service penetration. I can tell you so far the data that we've seen for service penetration has been fairly impressive. There's lots of geographic penetration in terms of the service being utilized all over Ontario. And hopefully we'll see similar data with Edmonton as well as with Alberta as well as with BC. Next slide. I think I've lost my connectivity. Okay.
We can still hear you.
Still hear me? Perfect. So the next steps, we have moved over to 24/7 phone line. We're going to be using Proctor's framework for implementation evaluation to see, again, some of these key implementation features: safety, penetration, acceptability, accessibility, and then also increased promotion of the service. We're also going to be using quality improvement metrics. So we're going to look at provider experiences, looking at how people who are on the front lines react to the service, patient perceptions on the service. We're going to be looking at outcomes, of course, as well, to see if we have proper service utilization, but also if there are potential decrease in mortality rates where these call-outs are, and we can do a lot of the stuff in Alberta. But then last but not least, looking at cost effectiveness, physical supervised consumption services are a costly endeavor. They are the gold standard, however. They cost anywhere from $3 to $5 million to operate. This phone line is a lot cheaper, so we can see if this can help increase the scalability of supervised consumption services to other communities. And with that, we have one last question. Do you think this service can work in your community? And what do you think are barriers and facilitators for its implementation in your communities as well? Thank you.
Thanks so much, Monty, and really appreciate the work that you guys are doing and really, addressing some of those barriers and the stigma that you mentioned. I think really important work. So folks, please feel free to chat in any thoughts, questions, or comments about what you just heard, and also to address Monty's questions. Can this work in your community? What do you think? All right, so we're going to continue moving right along here as I move the slide. So it's now my pleasure to pass the mic to Christina Dolkovitz, who's not far from where I am in Ottawa. She's based out of the Lanark Renfrew Health and Community Services, and she's going to be talking about the lung health program. So over to you, Christina.
Thanks, Neil. Hi, everyone. Good morning and good afternoon. As Neil said, my name is Christina. I'm a respiratory therapist, and I'm the coordinator of the lung health program out here at Lanark Renfrew Health and Community Services, which is about an hour west of Ottawa in rural Eastern Ontario. Next slide. So our Priority Health Challenge was focused on people living with COPD and to help keep them safe at home. So COPD stands for chronic obstructive pulmonary disease, mostly caused by smoking, although there are other environmental factors that can cause this. People with COPD can experience shortness of breath, a cough, maybe some sputum. It is a progressive disease, so unfortunately, once it's there, we can't reverse it. And so it does worsen over time. It can cause decreased physical activity, isolation, a lower quality of life, and people living with COPD tend to often experience high ED visits and hospitalizations. So what we proposed back in May when we signed up for the challenge was that we would focus with early screening and identification of people at risk, because the earlier we could identify, we could provide interventions, and also a 1-800 phone number for people with COPD to call if they're feeling unwell. A respiratory therapist would call them back and help them stay out of the emergency department. Next slide. So the biggest, I think, achievement for us was the fact that we engaged with patients. We had 3 amazing women who participated in our program, all living with COPD, who helped really drive the challenge forward in a way that maybe we didn't think of driving it forward. And that a big one was, how are we going to let people know about the emergency phone line? So with the patient's feedback, we now have a quarterly newsletter that's sent out via electronically, and also a Facebook page for our program, because unless the client was right in front of us, they would never know of all these quality improvement initiatives that we were doing, as well as the emergency phone line. You can see it in the top right-hand corner. So we printed off about 1,000 magnets thanks to some funding from CFHI from the Health Challenge, and was able to embed it right into the COPD action plan that we would print off and give to clients. Next slide, Neil. And of course, then COVID hit, which was a big challenge because we had big plans for the Priority Health Challenge. Made us do a complete flip, as everyone else on this phone call can appreciate. But I think when life gives you lemons, make lemonade, because the COVID forced us to shift direction to how are we going to offer our rehab program virtually, because obviously with restrictions in place, nobody could come on site now to participate in our rehabilitation program. And so in keeping with our challenge focus of helping people with COPD stay safe at home, is we've partnered with the University of Ottawa Heart Institute. They have an existing cardiac rehabilitation on their virtual care platform. And we're taking this existing platform that's been in place since 2016 and building our pulmonary components into it. And for those in our rural area, we experience a lot of clients who don't have access to internet. So we have purchased tablets, and we'll preload our program onto the tablets to loan out to clients, and which has caused a new development of our rehab flow and how we were going to measure this. I think the nice thing about this is the lemonade and the whole thing is that with the virtual platform and the tablets, now we can actually reach a much larger population than we were before, because before they had to be close to the rehab sites and they had to be able to get transportation to the rehab sites, and it had to fit within those 2 days that we were only on site to offer the program, where now it's like patients have the option of participating in which rehab program best fits for them. So I really feel our reach is going to be much larger because of this. Next slide, Neil. So next steps for us is, we had chatted before COVID hit. We were partnering with CFHI to help me host a town hall, in one of our small rural towns to partner with our patients, caregivers, and our community partners to really identify, okay, what are we missing here? How can we help support clients more in our community? And unfortunately, that was put on hold because of COVID, but I'm really hoping at some point we can take it off hold and move forward with that again. To continue with different avenues of reaching out to residents to let them know the services we offer and monitor the use of the emergency phone line. We didn't get the uptake that we thought we were going to get, and through the town hall, I'm hoping to figure out if that's really the best thing that we need to be offering clients, and if not, what else can we do to help them keep out of the emergency department.
Excuse me. Thanks so much, Christina, and it's really great to hear how you've managed to adapt given where things are at with the current environment. So really appreciate hearing the progress you guys have been able to make. Again, and Christina has posed the question, what are some ways that you are engaging with your patient reps during COVID? So maybe that's something we could tackle as a panel once we finish the presentations, but also feel free to chat in thoughts and questions. So we'll now move on to our next presentation. So it's now my pleasure to introduce Zaina Kayat, who's joining us from SC Health and who's going to be talking a little bit about their HOPE model, which is based in Ontario. So over to you, Zaina.
Thanks, Neil. Hi, everyone. Maybe next slide. So, you know, a lot of us work on trying to fix a lot of things in healthcare, and there's many things that are important to either clients and their family caregivers, to our health professionals, to our own organizations, and then to the system itself. And there's a lot of point solutions, and we do a ton of them. This is an effort to actually take on all four at once, because the current model of traditional fee-for-service, government central agency organized home care is just not working for anybody, and it's definitely not going to work going forward if we want to keep people at home, and if there's a new cost in all this called the personal cost of contact because of COVID. So I lead a futures team at St. Elizabeth Healthcare, which really is a framework, a methodology to do system change systematically, and this is a pretty transformational system change. So this was an effort to position and spread and scale this model, which we've been developing for more than 10 years at St. Elizabeth, called the HOPE model of home care. And just the next slide, we're not alone. There's a social movement around the world to emancipate from fee-for-service, top-down hierarchical models of really everything in org, but definitely in home care. And the logo didn't show up on this slide, but it's Buurtzorg out of the Netherlands really started it. They went, from a scalable model of, starting a different way to do home care, the way we've designed as well, with only 4 nurses and 50 clients in one little city in the Netherlands. And in just over 10 years, there are 15,000 nurses, 200,000 patients, the whole country, and now 25 other countries in the world are all part of a community of practice to really switch to this way of doing home care. And their results have been evaluated left, right, and center with, better results for clients and families. Nurses love it, and much better cost for the health system. So they've been a great partner for us because, we're trying to achieve that, using the levers we have here in Canada. So next slide, just what are we doing? I can't get into the detail. There's lots on the website, but the core of the model, you can see the 6 or 7 bullet points, fundamental differences from traditional care. First, we don't pay our nurses on fee-for-service, or our personal support workers are now part of this. It's a salary. It's a much higher salary, so we're at parity with, say, a hospital. They work in a neighborhood. The neighborhood is the client, not just our clients and families, so it's a geography bound. They work as a team, and they have no managers. It's a self-organized team, self-managed, a completely different skill set, letting them get back to their why they got into this profession. We went 100% paperless, so all digital, all the data is everywhere. Patients can access the data. We do wound care, remote monitoring, all the kind of smart stuff, and that helped us, glide through COVID without a blip at all, because we already were fully digital and virtual where needed. Real-time data measurement, because we have digitized everything. And I think the biggest one is not focused on medical tasks, which is what government pays us to do, but really what we call life care. So we started by, setting up 5 cities to test this. It spent a 1-year learning, and all that died with COVID because none of our funding partners could engage. And so we're down to 1 city where we'll finish out our pilot in about 2 months, and I think we have enough data to basically start transitioning to this model. So I won't get into the results on the next slide, but we did have a 9-point evaluation protocol. We had an embedded scientist, so all the quadruple aims and all those measures, but also a whole evaluation around the implementation and the scalability of the model, and just some results, basically like everything else we've seen. Anything you do that's better than what we do today in home care is a slam dunk for patients, for families, for our nurses who love it, who can't go back. But for our own organization and what's our sustainability to be able to keep doing this work, that's a very important one, and great data around the health system, but also a ton of learnings that we will continue to improve. And so just the last slide, in terms of next steps for us, we did adjust our plans because COVID really took a lot of the oxygen out of a lot of the partners we need to do this. But like I said, we'll finish our test site in north of London, Ontario, and really codify the results, share them with everybody who wants to learn with us. And our big one, and that leads to my question, is we cannot change the world by just doing this ourselves. So we really are creating like a playbook, like a step-by-step manual of how do you transition from a fee-for-service, very analog, very hierarchical model of home care to this model, on this journey with 25 other countries like Kaiser and China and many places. So we're writing the playbook now for the public, and we would love any people who have built playbooks like this to give us some, examples or tips or just some great ones, because I've seen some really bad ones, but I've seen some really good ones. And anybody who wants to learn with us, please join us on this journey. Thank you.
Thanks so much, Zaina. And again, I mean, what your FC Health is trying to do, really it's flipping things on its head. So it's amazing to hear more about the program and just things like paying PSWs, personal support workers at scale, focusing on life care. I mean, these are really important aspects that are revolutionary in some ways. So yeah, and if anybody has any examples of playbooks, I know at CFHI we've produced a few change packages for other types of programs. I know our Inspired COPD outreach program, we have something on our website. It might be a bit different, but there are different examples. But if anybody wants to share anything they're aware of in the chat box, feel free to do so. Yeah, and again, if you have questions for Zaina, please chat them in, and we'll come back in a few moments to address questions to everybody. So with that, I think we're now on to our 10th and final presenter, and thanks everyone for bearing with us. I know there's a lot of information, but it's really amazing to hear all the great innovations that are being shared. So our last presentation is from Sonia Kumar, who's joining us from the Body Brave Eating Disorders team, which I know this program is based in Ontario, but I know it's a collaboration with Eating Disorders Nova Scotia. So we're looking forward to hearing more. Over to you, Sonia.
Thanks, everyone, and a huge thanks to CFHI. So just a quick heads up that unfortunately wasn't able to get in our slides on time because we're a very small team and we're dealing with about quadruple in demand from individuals across Canada. So we are a bit overworked. So my apologies for that, but please don't hesitate to reach out if you have any questions. So I'd like to start off by talking a little bit about eating disorders just briefly because not many people know much about the condition. They are complex, biologically driven, very serious illnesses with the highest fatality rate of any mental illness. So prior to COVID, about 7.8% of the global population is impacted by an eating disorder, and only about 10% of those people receive specialized treatment. So gaps are anything from barriers to access, economic disparities, limited treatment options, and then that's all compounded by stigma and shame. So, in Canada, there's very little in the way of options for individuals. Often people have to be very sick in order to access care. And then in terms of after COVID, of course, a lot of the hospital treatments shut down or they reduced their capacity. So we're facing a real crisis right now across the country, really. A lot of those treatment programs are actually still closed or still at reduced capacity. The good news is with early intervention and rapid access to treatment, about 75% of people with eating disorders do recover. So if we can really get that number up, and if we can reach out on time, then people do recover from these issues. And as a side note, that eating disorders also impact families, they impact communities. I mean, it is a really large issue, and those of us who work in this sector consider it very much a public health crisis. So some of the problems we're dealing with, as I mentioned, was barriers to treatment, and also a lot of the organizations that are really on the front lines are small community organizations, nonprofits who have very few resources to work with. So we wanted to develop a person-centered virtual solution that provided accessible treatment and support by peer support workers as well as clinicians to clients who are struggling with eating disorders across the country. So we got together with a few different organizations, one in Saskatchewan, of course, in the lead is EDNS, Eating Disorders Nova Scotia, as well as Body Brave, as well as the National Initiative for Eating Disorders. And we started work on a virtual social learning platform that was designed by and for organizations across Canada that support individuals impacted by eating disorders. And I want to mention that this model is scalable for any mental health issue, but it was designed for those organizations that have very few resources. We don't have the time, we don't have the money to really have that proper tech support. We don't have staff that we need to spend 2 weeks training. It's not possible. We need to turn around within, say, 2 days. So given that, we created this social learning platform. So on this platform, individuals can access education modules, peer support groups, workshops, as well as treatment, which is all delivered by these community organizations. So when the pandemic hit, many of us had to switch virtual, as I know many of you have had to do that as well. So we wanted a way to quickly disseminate things like handouts. We also needed a way for people who are sitting on a wait list to access materials, learn a bit about our programs. We know from the research that for folks sitting on a wait list, it can be very detrimental just to sit there and not have anything to do. We also have features like live classrooms, discussion forums. There's opportunities for individuals to not only connect with each other, but also facilitators. So it's really a community space. It's a knowledge hub and a service delivery tool. In terms of our outcomes, we measured everything using Google Analytics, as well as some patient feedback forms. All of it was presented live on a Google dashboard, and it still is. So we were able to increase access to those handouts, increase access to care, reduce our wait times. Some of our statistics were that 60% of users completed an entire course or program, which means they went through each step of an online course. So just as a sort of context, the study conducted by Harvard showed that average course completion rates are at about 46%. So 63% is pretty good. One of our biggest things that we were really proud of is that Bridgepoint Center for Eating Disorders in Saskatchewan, their residential treatment program, they had to shut their doors completely, but thanks to the EdUE platform, they were able to put everything online and actually open up again and start offering services. So currently we have 270 participants registered and about 66 courses on the platform, and we're planning to keep on scaling it as much as possible. Thanks so much.
Thanks so much, Sonia, and really appreciate hearing about your program and how, despite, you don't have access to a lot of a big budget, it sounds like, or a big team, you guys have been able to really focus on addressing the needs of the people you're trying to support. And so really appreciate hearing what you're doing and being innovative and using innovative ideas to support your audience, your clientele. So folks, again, here on this slide, you'll see the last 5 speakers who shared their innovation. I'm just looking at the chat box. I think a lot of questions have been answered, but maybe I'll just raise this. I saw it come in, and I know it was embedded in some of your presentations, but wondering if anybody can share a little bit more about how they're promoting their program and really making sure people who could benefit are aware of it. And maybe I'll start. I'm just going to randomly pick. Maybe Zaina, I'll go to you, and any thoughts on that?
I think we don't have as much of a challenge with promoting because I don't think everyone's ready to move at this pace, but I will answer the questions on the screen. I mean, I think our biggest insight, even though we planned a 1-year test of change for each cohort, was how much of a mindset shift this is for our frontline nurses. So we recruited the people because they believed in the model, they wanted to work this way, but even then, task-focused care is still in the DNA. So I think if I could start all over, we would have done a lot more reprogramming at the front end than we did in our pilot.
Thank you. And maybe just to give people choice, maybe I'll go back to Sharon. Either you can, if you have any insights about what you would do differently next time, or what you would have known, and or you can talk about how you're promoting your program. Feel free to pick one that you want to address.
Yeah, we are working hard on many fronts, promoting this in primary care, in home care, making sure that people know about family caregiver needs and how important it is. Our family caregiver survey just went to 2 ministries, and it looks like they are behind us as we move forward with this program. It is a slog, but I think we're making some progress.
Yeah, no, that's it's probably a common theme from many of the presentations we heard today. It may not be easy, but I mean, you guys are all pioneers in really moving and pushing things forward despite some of the challenges and the context that you live in. So appreciate hearing that. Monty, I know you got some questions about how you're promoting the program. Do you want to share just a little bit more about that?
Yeah, 100%. And actually, I'm going to pass the mic over to my fearless leader, Kim, because she's done a lot of the work on this.
Okay.
Kim?
Yeah. So for us, with substance use in communities, let me be very clear. There's a lot of stigma and dehumanization that occurs. And so building a relationship with a service like this isn't going to happen fast. We had to earn that trust with the work that we do and our collective efforts, and the fact that we are a peer-run, peer-led organization of all of us having lived experience for the most part with substance use and mental health. It was easier to connect with folks through those platforms. We also did a lot of PR around this. We connected with local newspapers, we connected with local television networks, we contacted and we're in communication with almost every single harm reduction agency in Ontario and many across Canada as well. I've had people phone us from Australia even, asking us about how we implemented this and what this program is about, because they're interested and curious and they want to know how to go about it. We've had some pretty good success considering our resources. We also created cards, right? So we create these cards and they're plastic. And the reason we made them plastic is so when people are using them with their products, with their substances, they see our number and they call us. So it takes a minute. So like when Insight opened in 2003, I'm sure substance users weren't lining up around the block with dope in their pocket going to access that service. It takes a second. So through our collective efforts, hard work, and word of mouth, and relationship building we've done with communities, we've been able to have success with this. And we're very proud of those efforts, you know, and we have very firm stances politically on issues that impact our substance use communities, which also helps facilitate trust. So these are like a multifaceted effort besides your social media as well that allows us to do this. So, but we're also known for coming up with like innovative, groundbreaking harm reduction programs that nobody's ever attempted before. Which is, it helps, right? It helps that we have these reputations and we build this rapport with substance use communities, and we know that we're there to support them as people with lived experience. So these are like multifaceted venues upon which we've promoted this program. I hope that answers the question.
No, it does. Thank you. And it sounds like you're using multi-pronged approaches to really get the word out. Maybe, Christina, I'll go to you, and really I'll give you a choice. You can talk about something you wish you would have known, or how you're communicating, or really how you're engaging with patients, which you spoke to a little bit already.
I think one of the things I wish I would have known is we had an EMR switch over March 1st of last year, and implementing a new quality improvement initiative while we have, you know, a 4-day-a-week data manager for 2 community health centers. In the middle of a EMR transition, that was challenging, and even pulling the data today is still challenging, so I'm having to do a lot of the behind-the-scenes data work myself. And as for communication strategy, I mean, like most of us, we have a pretty limited budget. I have no budget for communications at all, and so often it's just off the side of my desk. How are we going to manage social media? How are we going to communicate with those clients outside of our community health center? And so those are challenging things because it is hard to get all of that information out to clients. It's overwhelming to them. So how can we do it in a meaningful way with basically no resources? And so those are big things that we've had to think about this year, and just, how can we move forward with ensuring that outside residents, so residents in the region that we serve, know about the services we offer.
Thanks so much. Yeah, no, it sounds like it's a common challenge for many. Sonia, maybe last question to you. How are you communicating your program?
So all of our programs are communicated mainly through Instagram, social media. So we have a pretty large following of about 17,000 on social media. But we're also running a virtual conference, and we're actually running it on the ePlatform, EDU platform, because it is so flexible. And we thought, hey, why not get folks familiar with it and comfortable with it? So we'll be rolling that out in November 19th and 20th. So those are the primary ways we talk about our program.
Thank you so much. And I think we're almost at time, folks. I did want to share, and first of all, I want to thank all of the excellent presenters for sharing all the great work you're doing. And I will share that Barb had a really positive comment from Providence, and she said these are some of the most inspiring presentations that I had seen. Many have shared aspects of their project that are transferable even in small ways to other initiatives. Couldn't agree more. I think there's a lot of commonalities, even though they're in, some might be addressing mental health, some might be addressing home and community care, but a lot of things that are really transferable. And I think Danielle from CVI is asking, is there a contact info for the mental health and addiction program? Maybe, Danielle, I'm not sure if you could be more specific and we can get you that information. So with that, I just wanted to let folks remind people that our final webinar in the Challenge, Priority Challenge series is November 16th at noon Eastern Time, and it'll really focus on celebrating success and maintaining momentum. Once again, thank you to our wonderful speakers today, and to all of you who took the time to participate and be part of this conversation and really helping spread the word. And I'll just ask that before you log off that you take a few moments to complete the feedback polls, which you'll see on your screen. Have a wonderful day, everyone.
This concludes today's webinar. Thank you, everyone. You may now disconnect.